Bismillah ar-Rahman ar-Rahim. We will start with quote of the day, which is from the Surah Mulk in Quran. It is He who made the earth tame for you, so walk among its slope and eat of His provision, and to Him is the resurrection. Resurrection. My name is Dr. Taimia Ayub. I am FCPS trainee, and today I will be presenting the topic of typhoid under the kind supervision of Professor Dr. Zaira Afzal, Dean Institute of Public Health, Lahore. These are the learning outcomes of today's lecture. We will start with introduction, then we will cover epidemiological factors, chain of transmission, clinical manifestations, diagnosis, and management. Then we will apply the levels of prevention. And finally, we will do the burden of disease and recent advances in typhoid. And at the end, we will do multiple choice questions. And this is the learning outcome of today's lecture. So, what is typhoid? Typhoid and paratyphoid fevers are commonly grouped together under the collective term enteric fever. Typhoid fever is caused by Salmonella enterica serovir typhi, and paratyphoid fever is caused by either Salmonella paratyphi A, B, or C. Both Salmonella typhi and Salmonella paratyphi cause a fecal oral transmitted systemic disease. However, paratyphi causes a less severe illness. WHO estimates that global typhoid fever disease burden at 11 to 20 million cases annually, resulting in about 128,000 to 161,000 deaths per year. Typhoid fever is endemic in Asia, Africa, Latin America, the Caribbean, and Oceania, but 80% of the cases come from Bangladesh, China, India, Indonesia, Nepal, Pakistan, or Vietnam. Typhoid risk is higher in populations that lack access to safe water and adequate sanitation. Poor communities and vulnerable groups, including children, are at highest risk. Now we will explain some terms related to typhoid. So, what is multi-drug resistant typhoid? It is the when the typhoid is resistant to three antibiotics like penicillin, trimethoprim, sulfamethoxazole, and chloramphenicol. And what is XDR typhoid? When it is resistant to five antibiotic like chloramphenicol, ampicillin, cotrimoxazole, fluoroquinolones, and third generation cephalosporins. And only three antimicrobial drugs like azithromycin, oral, carbapenem, and one parenteral are effective against the XDR strain, sorry. So, drug resistant typhoid. Now we come to epidemiological determinants. So, what is the agent? Salmonella typhi is the major cause of enteric fever. Salmonella typhi A and B are relatively infrequent. It has main three antigen O, H, and V1. The factors which influence the onset of typhoid fever in man are the infecting dose, and virulence of the organism. Now we come to the host factors, which include age. Typhoid may occur at any age. Highest incidence of this disease occur in 5 to 19 years of age group. It is more common reportedly among males than females, probably as a result of increased exposure to infection. Immunity, according to immunity, all ages are susceptible to infection. Antibodies may be stimulated by the infection or by immunization. Among the host factors that contribute to resistance to Salmonella typhi are gastric acidity and local intestinal immunity. So now we come to the determinants. First of all, we have the primary determinant, which is the causative agent, Salmonella typhi, which is gram-negative bacillus. Now we come to secondary determinants, which include unsafe drinking water, poor sanitation and hygiene, overcrowding, low vaccination rate, poor surveillance system, travel to endemic regions. It is a very frequent disease. Global incidence is 9 to 12 million cases per year, leading to approximately around 100,000 or even more deaths per year. And as explained, highest burden is in South Asia and Africa, some countries. So, source of infection, humans are the only reservoir. Acute cases, subclinical infection, and chronic carriers are the main sources. For example, chronic carriers are the one with gallbladder colonization. I will explain all these terms later. Period of communicability begins 1 to 2 weeks before symptoms. It continues throughout illness, and chronic carriers can excrete bacteria up to 1 or even more year following infection. Incubation period is usually 10 to 14 days, but it may be as short as 3 days, or if the 3 weeks, or can be up to 3 weeks depending on the dose of the bacilli ingested. Mode of transmission is by fecal oral route, which can occur through contaminated food, water, or ice. Handlers can be the one shedding organism, and flies can act as mechanical vectors. Clinical features include signs and symptoms like stepladder fever pattern, abdominal pain, headache, malaise, anorexia, relative bradycardia, also known as fidget sign, splenomegaly, or rose spots, which are not that common. These are, as you can see, some of the symptoms of typhoid fever as explained in the figure. It includes high fever, chills, loss of appetite, stomach or abdominal pain, rose spots usually on chest or stomach, cough, muscle aches, headache, nausea, and diarrhea. Clinical features can include complications like intestinal perforation, gastrointestinal bleeding, encephalopathy, hepatitis, myocarditis, or chronic carrier state. So now I would explain some of the definitions which are related to the typhoid, like case definitions. So what is a suspected case? It is a person with fever more than or equal to 3 days, as sorry, less than or equal to 3 days, and headache, abdominal pain, or constipation, diarrhea, and living in coming from typhoid endemic area without another obvious cause of fever. And so probable case is the one when suspected case with positive typhoid or Vidal test or epidemiological link to a confirmed typhoid case or clinical features strongly suggested of typhoid like stepladder fever, relative bradycardia or splenomegaly. And then we have confirmed case. Any suspected or probable case with isolation of Salmonella typhi from blood, stool, urine, or bone marrow, or PCR positive for Salmonella typhi. Blood culture is the gold standard in this case. Now we come to the definition of types of carrier. So first of all, we have convalescent carrier, which excretes Salmonella typhi during recovery. Shedding lasts can up to 2 to 3 months after illness. Then we have temporary short-term carrier, which excretes bacteria for a few weeks to less than 3 months. It is common in children. Then we have chronic carrier, excretes Salmonella typhi for greater than 1 year, sometimes decades, often linked to gallbladder colonization, major public health risk, especially if a food handler is involved. So then we have healthy carrier, which don't have any symptoms but sheds organism, can be temporary or chronic, or and contact carrier, which acquires and sheds bacteria after close contact with a case. It is short-term excretion. Now we come to the types of vaccine which can be given in cases of to prevent typhoid. We have type 2A LA vaccine and the unconjugated Y polysaccharide VIPS vaccine, and then typhoid conjugate vaccine. Typhoid conjugate vaccine is the one which is given intramuscularly in single dose 0.5 ml in children greater than 6 or equal to 6 months of age, and in adults up to 45 years of age. So this is the common being given. In Pakistan, these are the vaccines currently available. We have Vivotif is a live attenuated vaccine for oral administration only. The enteric coated salmon white capsule are then packaged into 4 capsule blisters for distribution. Then we have single dose of injectable polysaccharide vaccine for children greater than 2 years of age. Revaccination is needed every 3 years for continued protection. And then we have single dose of typhoid conjugate vaccine is approved for use in children greater than 6 months of age. Offers protection for at least 3 years to adult and then to adult children and infants over 6 months of age. And revaccination schedule is being planned. So, who should be vaccinated? Everyone should be vaccinated, including or in cases of spread of typhoid, all household members of a confirmed case, including adults and children over 6 months of age. all healthcare workers, and all food handlers. So, how to diagnose typhoid? Blood culture is the gold standard test for the diagnosis of typhoid and must be sent before starting antibiotic. The culture of typhi can be done from blood, bone marrow, urine, rose spot, biopsy extract, duodenal aspirate, and stool. Empirical treatment for typhoid should not be commenced without obtaining blood cultures. It can be taken even if patient is currently afebrile. A negative culture does not exclude typhoid and may warrant a repeat blood culture if the fever is not responding in 7 to 9 days of commencing treatment. Serological tests like Vidal and Typhidot are not recommended in the diagnosis. Both have low sensitivity and specificity and do not provide information on antimicrobial sensitivity. Now we come to the treatments. Fluoroquinolones are widely regarded as the drug of choice for the treatment of typhoid fever. They are relatively inexpensive, well tolerated, and more rapidly and reliably effective than the former first line drugs like chloramphenicol, ampicillin, amoxicillin, and so on. So these are the first line antibiotics like chloramphenicol, trimethoprim, ampicillin, amoxicillin. Then we have second line antibiotics, and then we have third line antibiotics, which include, as you can see, azithromycin, meropenem, imipenem, and entropenem. So management include a supportive care, which consists of hydration, giving antipyretics, and right nutrition. Public health measures for management includes identifying of cases, safe water and sanitation, and making sure that food is being handled properly either at home or in restaurants or commercial spaces. So now we will apply the three levels of prevention, like primary prevention, secondary prevention, and tertiary prevention. Primary prevention, as I have explained previously, it includes vaccination, which is typhoid conjugate vaccine and single dose at 9 months or 2 years. It depends upon the country's specific schedule. Pakistan has introduced typhoid vaccine in EPI program. It gives protection for 3 to 5 years. Then making sure that we have safe water by chlorination and boiling. Excuse me, and then improves toilet access to all the people and improving hygiene and hand washing by public health campaigns, and then making sure that food is prepared and eaten in a safe manner by community education. Now we come to secondary prevention, which is first of all early case identification. If the fever is greater than 3 days, if there are abdominal symptom, or if there is exposure risk present, then by laboratory confirmation, treatment of confirmed cases, isolation and food handler restrictions, and contact investigation during outbreak, strengthening surveillance system, and safe water intervention during outbreak. Now we come to tertiary prevention, which include management of complication, surgery in case of perforation, rehabilitation after prolonged illness, public health follow-up of chronic carriers, community hygiene education to prevent reoccurrence. Burden of disease. The global burden of typhoid. Magnitude can, it is hypothesized that 9 to 12 million cases, and as I explained, more than 100,000 deaths are reported annually, mostly affecting children of 5 to 15 years. Highest burden in countries of South Asia and Sub Sahara Africa, particularly Pakistan, India, Bangladesh, Nepal, as I explained. So, antimicrobial resistance, increasing multi-drug resistance, and XDR typhi is being reported. XDR strains reported from Pakistan and travel-related cases in several other countries. WHO notes typhoid is vaccine preventable, but vaccination remains low in many endemic areas, and WHO recommends introduction of TCV in all high-burden countries. So this is the typhoid and paratyphoid fever death rate in children under 5, 1980 to 2021. As you can see on the left side, this is the situation which was present in 1980, and this is the situation present in 2021. Unfortunately, you can see that in Pakistan and India, the situation remained the same. And in all other countries, they have improved a lot. Even the African countries are doing way better, except from this red center, or even the African countries are doing way better. I think this is Vietnam, than the South Asian region. So we need to do more measures. Whatever being done, there is definitely need to be done more. So, the national burden of typhoid. Pakistan is a high burden country. It is among the highest typhoid burden countries globally, estimated zero point 0.6 to 1 million cases per year. XDR typhoid was detected in Karachi in 2016, now present in all provinces. It is resistant to multiple antibiotics, leaving azithromycin as the main oral option. High risk group include children, as explained, 2 to 15 years old, informal settlements, slum areas, areas dependent on unsafe water resources, street food exposed population. National challenges include poor sanitation, contaminated piped water, antibiotic misuse, limited culture-based diagnosis. National response. Pakistan was the first country to introduce typhoid conjugate vaccine TCV in routine EPI schedule in 2019 to 2021. And the strengthening of surveillance and AMR monitoring is should be done. Recurrent outbreaks in Karachi, Hyderabad, Lahore, Rawalpindi, especially during water shortages or post-flood period. This is the typhoid and paratyphoid death rate by age in Pakistan. As you can see, in 1980 to 2021, there has been slight improvement, especially in the under 5 rate, but still it is quite high. The second most common group is 5 to 14 years of children. Rest of the group is at low level and it's relatively they are still below 5. Now we come to recent advances. Research has highlighted the overuse of azithromycin to treat COVID-19, and this practice might impair one of the few remaining solutions against XDR Salmonella typhi. Facing COVID-19 and XDR simultaneously can result in a catastrophe in Pakistan because it is entirely occupied with the pandemic. This was from the paper. Ceftriaxone-resistant Salmonella enterica serovir paratyphi A identified in a case of enteric fever, first case reported from Pakistan. So, in this paper, they highlighted the occurrence of plasmid-mediated ceftriaxone-resistant strain of Salmonella paratyphi. It was of significance as ceftriaxone is commonly used to treat paratyphoid fever, and resistance in Salmonella paratyphi A is not known. Continued epidemiological surveillance is required to monitor the transmission and spread of AMR among typhoid salmonella, and this will guide treatment options and preventive measures, including the need for vaccination against Salmonella paratyphi in the region. So now we come to the multiple choice questions. A massive typhoid vaccination campaign is underway in Pakistan, using which type of typhoid vaccine to protect kids of age 9 months to 15 years. Type 21A vaccine, Y polysaccharide vaccine, typhoid conjugate vaccine, typhoid toxoid, or typhoid life vaccine.
C.
Yes, typhoid conjugate vaccine is the one which can be given to the children 6 months and onwards. Research has highlighted the overuse of azithromycin to treat COVID-19, and this practice might impair one of the few remaining solutions against which type of drug resistance: multi-drug resistance, extensive drug resistance, methicillin drug resistance, penicillin drug resistance, or ampicillin drug resistance. Type of typhoid.
D.
Yes, it is extensive drug resistant typhoid. Worldwide drug resistance against Salmonella typhi is quite difficult to treat. What do you understand by the term extensively drug resistant typhoid? Salmonella typhi sensitive to the first line antibiotics and third generation cephalosporin, or it resistant to first line antibiotics with or without second line antibiotic, uh, and or resistant to 5 classes of antibiotics including chloramphenicol, ampicillin, cotrimoxazole, streptomycin, fluoroquinolones, and third generation cephalosporin, or cephalosporin resistant to all types of recommended antibiotics except 3, or cephalosporin, Salmonella typhi resistant to third generation cephalosporin only.
D.
Yes, Salmonella typhi, all types of recommended antibiotics except 3. There are multiple case definitions which describe the carrier state of typhoid fever, which laboratory test to confirm the chronic carrier stage of typhoid fever. Blood culture, stool culture, urine culture, withdrawal test, or PCR test. It is for the diagnosis of chronic carrier state of typhoid.
B.
Blood culture? C.
Yes, for chronic carrier, stool culture should be done. According to recent guidelines, blood culture is gold standard for the diagnosis of typhoid fever. Why withdrawal test is no more recommended for gold standard. Low sensitivity and low specificity, low sensitivity and high specificity, high sensitivity and low specificity, both high sensitivity and low specificity, or the sensitivity or specificity cannot be determined.
A.
Yes. A restaurant chef is diagnosed with typhoid. What should the public health team do first? Allow return to work after 48 hours of antibiotic. Restrict from food handling until cultures are negative. Start prophylaxis for customers. Close the restaurant for 1 month. Perform withdrawal test on all staff.
B.
B.
Yes, it's B. In a flood affected district, typhoid cases rapidly increase. What environmental factors most likely drives this rise? Increased temperature, contaminated water sources, decreased mosquito density, more school closures, reduced migrations.
B.
Yes.
B.
Yes. 14-year-old girl with typhoid develops sudden severe abdominal pain and guarding. What complication is most likely? Hepatitis, rose spot, intestinal perforation, anemia, or pancreatitis?
C.
B.
Yes.
C.
Yes, it's C. A community reports repeatedly typhoid outbreaks despite treatment campaign. Which long-term strategy has the greatest impact? Free antibiotics, short-term isolation centers, comprehensive wash improvements, weekly withdrawal testing, or more private clinics.
C.
C. C.
Yes. A mother asks why her vaccinated child still needs hand washing education. What is the best response? Vaccination gives 100% protection. Typhoid spread only by water. Vaccination reduces but does not eliminate risk. Hand washing is optional. Hand washing protects only adults.
C.
Yes.
C.
So, yes, this is the answer key, and the video will be uploaded on our YouTube channel. And thank you very much for listening.
Thank
Dr.
you,
Taimia.
Tamia, because it was a very